any kind of thing that you lose weight, not just lose fat mass, but there'll be some muscle mass loss as well.
Okay.
Yeah, and so it is also important that when we actually counsel a patient for Ozempic, that we don't neglect the other aspects of weight management, which is your lifestyle. Exercise is very important because that will help to keep your muscle mass. I always tell my patients, these medicines are, yes, very good. They've been game-changing in terms of obesity, but they're not a magic pill.
Yes.
Right? It doesn't take away the importance of lifestyle measures as well. We are fortunate in a way that we're living in a time where there are good treatments for obesity where we previously never had.
Yeah.
Right? And patients now have a fighting chance of actually really getting better and really improving their health. I try to emphasize to them, taking all these medicines is health over appearance. Right?
Yes.
Right. Ultimately, it's actually for the good of your health in the long run and everything.
Hello and welcome to today's episode, The Skinny on Ozempic, Weight Loss Miracle or Medical Hype, where we dive deep into the latest health trends and medical insights. I'm your host, Dr. Chai Ling, and today we're unpacking a topic that's captured the attention of both the medical community and the public alike. We're talking about Ozempic, a medication initially used to manage diabetes, but now making waves in the weight loss world. Is it a miracle solution for shedding pounds, or is there more to the story? Joining us to explore these questions is Dr. Daphne Lee, Medical Director and Consultant Endocrinologist at the Dr. Daphne Lee Endocrine and Diabetes Medical Clinic. With a rich background in general endocrinology, focusing on conditions from diabetes, adrenal disorders, and a passion for educating the next generation of healthcare professionals, Dr. Lee brings a wealth of knowledge to our discussion. Welcome to the show, Dr. Lee. So tell us, the latest thing is this craze on Ozempic.
Yeah.
What exactly is Ozempic?
Yeah, so actually Ozempic is the kind of like the brand name for something called semaglutide.
Yeah.
Right, so semaglutide is actually the main ingredient in Ozempic.
Okay.
And semaglutide itself belongs to a family of medicines, a family of drugs actually called GLP-1 receptor agonists.
Okay.
It's a mouthful, but essentially it stands for glucagon-like peptide receptor agonist.
Okay.
And basically what semaglutide does is that it mimics the natural action of this hormone. Right? So GLP-1 is naturally produced in our bodies, produced by our gut in response to food.
Okay.
Right? So when you consume something, it gets digested, right? And this triggers the release of GLP-1 right, from our intestines. And GLP-1 in turn triggers insulin release from our pancreas.
Okay.
Right? And insulin is very instrumental in basically sugar control, regulating our sugars, bring our sugar level down after we eat. Okay. And so GLP-1 is responsible for, it's one of the factors, one of the mechanisms involved in triggering insulin release after a meal. Okay. That helps to bring our sugar levels down.
Okay.
Yeah. And so that's the chief mechanism by which semaglutide and therefore Ozempic works.
Okay. Yeah. So essentially it is used to bring blood sugar down for people with type 2 diabetes.
Yeah, that's right.
Okay.
Yeah, that's how it started. So actually the science behind GLP-1s goes back a long way.
Yeah.
And the hormone was actually discovered like in the 1970s, 1980s.
Oh, okay.
Right? Yeah, so the science is not new, but it took many years before a drug actually was, many years of research and everything, and testing and trials before the first GLP-1 was released in 2005.
Okay.
Yeah,
okay.
and then Ozempic, right, which is semaglutide, came out in 2017.
Okay.
So actually it has a long history. I mean, I wouldn't say long, but it does have quite a history behind it.
Yes.
Yeah.
So, this hormone, right, the GLP-1, that's also the hormone that makes a person hungry. It gives them a feeling of fullness, actually.
Yeah. And so actually, so semaglutide actually started out, GLP-1 started out as diabetic medicine. So they're designed for diabetes patients because of its effects on blood glucose. But along the way, they found that actually a lot of these patients were losing a considerable amount of weight. Okay. Right? Diabetic patients. And as we know, diabetes and weight is closely related, right? So losing weight does help diabetes. And they found that actually beyond its effects on sugar lowering, it actually acts on your digestion, right? It makes you feel full faster. It slows down the rate of digestion. And also it kind of has this effect on the interplay between your hunger impulses and your satiety impulses in the brain.
I see.
Right? So it kind of like balances this out. So it reduces the hunger signals or increasing satiety signals. And that is actually one of the main ways in which, medicines like Ozempic result in weight loss.
That sounds great. It's just that when we hear it in the media, nobody really talks about Ozempic for diabetes. But I hear that like half of Hollywood is taking Ozempic for weight loss. Is that the case in Singapore?
There has certainly been a lot of interest, right, in this class of medications because, if we go maybe slightly a bit earlier before Ozempic came out, we didn't have very good options for weight management, right, in terms of medications wise lah. And the earlier GLP-1s, like the ones that came out in 2005 and is the predecessors to Ozempic, actually, I wouldn't say they are not effective, but
what were the predecessors? The Saxenda, the daily injections.
Yeah, that's right. Yeah, the expected efficacy we expect is around 5 to 6%, right, weight loss, whereas Ozempic gives about 10-15%.
Wow!
So patients generally would lose about 10-15% from their baseline. But of course, this takes place over a period of time.
Yes.
Yeah.
And I think daily injections just tend to be more tedious than weekly. I would be,
of course. Yeah. So the predecessors to Ozempic, right, within the same class, they were either the very first one, I think, is like a couple of times a day even.
Oh my God, then, okay, because so short acting, right?
And then the Saxenda was actually formulated for obesity management.
Okay.
So it's actually its original counterpart was something called liraglutide Victoza. That was the version that was used for diabetes. And then they came up with a version that was for obesity.
Obesity.
Yeah, so that is Saxenda. So Saxenda, yes, is a daily injection.
Yes. I do have patients on a Saxenda because in Singapore, Ozempic is only indicated for people with actually diabetes. So when my patients want something closely similar to Ozempic, then we have only Saxenda or the oral medication, Ribulsis.
Yes, that's right. Yeah. So actually, the official label, right, for use of Ozempic is type 2 diabetes patients, right? It's actually confers not just sugar-lowering properties, right? As we know, weight loss. And actually, what has been really groundbreaking in terms of diabetes management nowadays is like medicines like GLPs, Ozempic, they have been found to be organ protective.
Oh, that's very interesting.
Yeah. So the additional benefits are that, in type 2 diabetic patients who, let's say they have risk factors, like maybe they got some heart problem before, or kidney is not so good. And, we are always fearful of diabetic-related complications, right, in these organs. So, Ozempic and, GLP-1s in general, have been shown to actually be, reduces the risk of this kind of complications from progressing.
Right. Okay.
So, actually the benefits go beyond that. So yes, it's a game changer and there's been a lot of interest in this.
Yeah.
I wouldn't say half of Singapore is on it, but yeah.
But do you put what is your typical patient that would be ideal for Ozempic in your practice?
The ideal patient, I would say, is someone who's diabetic and maybe needs to lose a bit of weight.
Okay.
Right? So that's official label. Actually, I mean, a lot of times we also do consider, so let's say if the patient maybe not diabetic, maybe pre-diabetic, or maybe they have hypertension, or they have obstructive sleep apnea, or some issue relating to the weight, but at the same time, they are overweight, right? Maybe their BMI is, high lah, right? They may not be diabetic yet, so in these circumstances, it's acceptable generally to use Ozempic as an off-label indication.
I see.
Yeah, so we use it off-label in patients who need to lose weight, but maybe not necessarily diabetic yet.
Okay.
Yeah, because the efficacy is generally more than what you would get with Saxenda.
Understand. So for patients like these, how long do they have to take before they see actual weight loss results?
The way the medicine is being given is that it's a titration process. So actually there are 2 or 3 forms of semaglutide. So there's the oral form, as you mentioned, Ribulsis. That is taken every day. And then there's Ozempic, which is once a week injection. There's actually a higher dose formulation called Wegovy.
Okay.
It's semaglutide at a higher dose. And this one is actually indicated for diabetes. Not diabetes, I beg your pardon. Indicated for obesity.
Obesity.
So it's kind of like the equivalent to Saxenda, but it's not available in Singapore yet.
That's why we don't hear so much about it.
Yeah.
Okay. But higher dosage, doesn't it also mean more side effects?
Potentially, yes. And so there's a titration process.
Okay.
Right. So maybe we take Ozempic as an example. So it's a weekly injection. When I first start the patient on it, right, we start at a low dose.
Okay.
So at like a 0.25 milligrams per week. And we do this for 4 weeks. So they get 4 doses, and after 4 weeks, if they are feeling fine, they are not having too many side effects, then we increase the dose to 0.5 milligrams per week.
But during the first 4 weeks, do they already have some weight loss benefits sort of, like, to motivate them?
Maybe not much.
Okay, not much yet. Okay.
Yeah, you probably won't see so much in the first month.
Okay.
Yeah, so you really only start to see effects maybe third month onwards, because that's where you get to the full dose.
I see.
So first month low dose for 4 weeks, then medium dose, which is for Ozempic will be 0.5 milligrams for another 4 weeks. And then it goes up to the full dose of 1 mg per week.
Is that the highest they can go and stay there?
Actually, not really. In Singapore, we have up to 1 mg.
Okay.
Yeah.
But worldwide?
They have formulations go up to 2 mgs.
Okay.
Yeah, so that's in the US and places.
But why do you think in Singapore we limit to 1 mg? Because we're Asians, we're smaller size.
Maybe it could be.
We're more careful.
It could be the drug company consideration as well, that maybe they feel 1 mg is good enough for this market. Yeah,
really?
Yeah.
Do you think that we have less obese people in Singapore?
Compared to perhaps
in America, and that's why maybe they're limiting it.
It could be, and maybe also the Asian body composition. Because for example, our cutoff for BMI is lower than in the Caucasian population, right? Yeah.
Okay.
So perhaps some of these considerations is the reason why we have up to 1 mg. And I would say most of the time 1 mg works well enough
so your
for
patients,
us. Yeah. Wegovy, on the other hand, goes up to 2.4. So the titration process is slightly longer.
I understand.
Yeah, for them to reach that 2.4 mg dose.
But I mean, it doesn't sound like we need it, because in your practice, your patients that have been Ozempic, they already definitely see some improvement in blood sugar.
Yes.
And they, those that are obese, all do see some weight loss.
Okay, so there's a spectrum in terms of how patients respond.
It's not for sure.
So generally you expect 10 to 15%. Of course, some patients are on the 10%
of the weight.
Scale.
So like if I'm 100 kg, I would think I'll lose 10 kg.
Yeah, 10 to 15% from your baseline.
Yeah.
So some patients are maybe on the lower end of the spectrum. Some patients actually maybe lose a little bit more than 15%. Non-diabetic patients seem to lose more weight compared to diabetic patients. And this weight loss occurs over a period of time. Like I said, in the first few months, because they are still on kind of like a titration process to get to the full dose, you may not see a lot of weight loss. I have patients that lose maybe a few kilos, 2-3 kilos, like a little bit of weight loss in the first 2 months. But I would say most of the time we tend to see the effect kick in
when they're on the
full dose. Yeah, and they've been on the full dose for perhaps a few months. You see the weight loss start kicking in. And I mean, the studies and the trials of this drug is usually over a period of like 1 year, 1.5 years, thereabouts. So this weight loss is gradual. Takes time, and it's not like continuously right? It's not like 100 kg keep losing
it will taper off, obviously.
So it will hit a plateau, and then as long as the patient is on medication, then the weight loss will be maintained. That's generally the trend.
So the way you titrate it, is it because you're worried about the side effects, or is it because by titrating it this way, they will experience less side effects?
Yes, on both counts, you're right. So the reason why it's designed to be given this way, is because predecessors of Ozempic, when you give them higher doses or maybe a very short titration period, the side effects can be quite overwhelming for patients.
Oh, really? What were we going to look out for?
So I would say the most common thing people experience is nausea.
Okay.
They feel like, very sick. They can't eat.
Oh, terrible.
Sometimes to the extent that they have vomiting, diarrhea, constipation. So mostly GI related.
GI related. Okay.
Of course, there have been some stories in the press and social media about people getting so dehydrated to the extent they end up in the hospital.
Wow. Okay.
But I think if we follow the titration process,
it shouldn't
happen so much.
I think with any crash diet, you always hear these dramatic stories. But I think if you are responsible and you do it, then it should be okay.
I mean, in my experience, from the number of patients that we've been giving Ozempic and Rybelsus, even for that matter, I think if you start a low dose, like for Rybelsus, it's 3 mg right? So start at 3 mg, then you titrate. Sometimes some patients need a bit longer. Like maybe they say, okay, maybe I want to do it over 6 weeks instead of 4 weeks.
Okay.
I think it's all right, as long as it's, it may take them a bit longer to reach the full dose, but if there's comfortable pace for them,
why not?
Why not? Yeah.
So these patients with the side effects, if they keep at it because they're so adamant they want to lose weight, does the side effects get better?
They do get better.
Okay.
Yeah. So the side effects do get better over time.
Okay.
Right. It usually occurs like when you first start. Right? So maybe first few days, and the nausea most of the time is not like last 24 hours a day kind of thing. So some patients will say that, okay, like I feel a wave of nausea.
Okay.
And then it goes away as suddenly as it comes.
Right.
It gets better with time. But when you increase the dose, let's say you're moving from low to medium.
Yes.
And then medium to the full dose,
Yeah.
right? When you increase the dose, maybe a few days, you may feel a little bit of that nausea sensation. But studies have shown it gets better with time.
That's interesting.
Yeah.
So, all these patients that lose weight, is there any studies showing whether, is it mainly fat loss? Do they lose a bit of muscle as well?
So this has been examined with Ozempic, right? Particularly with the interest in its weight loss effects. So as with any kind of thing that you lose weight, right? You not just lose muscle, not just lose fat mass, but there'll be some muscle mass loss as well.
Okay.
Yeah. And so it is also important that when we actually counsel a patient for Ozempic, that we don't neglect the other aspects of, weight management, which is your lifestyle. Okay. Exercise is very important because that will help to keep your muscle mass.
I see. So your ideal patient is somebody who's also motivated to sort of exercise and do some dietary
definitely.
control.
Yeah, because it's important to kind of have an open and frank discussion with the patient and to set the expectations right from the beginning.
Yeah, exactly.
Yeah. So I always tell my patients, these medicines are, very good. They've been game-changing in terms of obesity, but they're not a magic pill.
Yes.
Right? It doesn't take away the importance of lifestyle measures as well, because this is what is going to sustain you as well in the long run. It's a foundation upon which we build up all these things. So I tell them, it doesn't, I don't want them to get the impression that, I take this medicine,
it's a magic pill. Yeah, they can eat anything.
Yeah, I can.
That would be the worst thing ever.
So then it kind of defeats the purpose.
Okay, because it's really expensive, right?
Yes,
Ozempic. I mean, how much are we talking about?
Probably talking about, if let's say you're on the full dose regularly, maybe $300-400 a month.
A month, right?
Yeah.
So for diabetes, I presume the patient must be on it forever. Or are they going to decrease the dose, or are they going to trial stop? Or?
Yeah, so if you're giving it for diabetes, and let's say the patient is also diabetic at the same time, well, these medicines are designed to be given long term. Yeah. Right? So it's not meant to be stopped.
Yeah.
Right?
So it's a long term medicine,
so,
like any diabetic
correct.
medicine.
And also, beyond weight loss, if you want to maintain those benefits, the cardioprotective benefits and stuff like that, then it's meant to be given long term.
I see. How about then for obesity? Are they going to be paying a few $100s forever? Or when they stop, do the weight come back? Or is there a chance it stays up?
Yeah. So there have been some trials where people stop Ozempic, right? So like, for example, a group of them maintain on for another year and a group of them stop. The reality is that when you stop the medicine, the benefits will diminish, right?
Okay.
So they do tend to regain some weight. Yeah. Right. I always tell them, if you are good with your diet, exercise, everything, hopefully that weight loss will be gradual and it will not be so much. So the importance of emphasizing that aspect of things right from the beginning. Yeah. So, but yes, actually we're also increasingly understanding that, if for obesity itself, it's probably a bit like diabetes, hypertension is a chronic condition.
So you would encourage somebody that struggles with obesity to maybe maintain some amount of this medicine forever?
To maintain the benefits of the medicine, which includes the weight and the other metabolic health benefits that you're getting, it's probably better if you keep on the medication than if you were to stop it. Yeah. So it's not something like, I take 1 month course and then I'm done with it kind of thing.
Yeah, because with the older weight loss medicine, especially like the phentermines, we usually never give beyond 3 months because the side effects and the addictive potential. But I think Ozempic is actually very different because it's actually for diabetes and people have used it all their life. So that, apart from the cost, if people really struggle with obesity, they can actually use this for long term.
I would say potentially, yes.
Yeah. And then you talk about this cardioprotective effects. In the studies, what sort of benefits are they looking at? That means reduce heart attack risk,
reduce the risk of, like things like heart attacks, strokes, basically death from cardiovascular causes. Okay. Reduces retards the progress of, diabetic nephropathy, kidney disease. It reduces the risk of end-stage renal failure, and things like that. So it has been one of the, I would say in the recent years, in recent years, the diabetes treatment landscape has been changing and evolving. Yeah. And actually, in addition to GLP-1s, including Ozempic, the later, newer diabetes medicines have actually been shown to confer this kind of organ protection, which is actually an added benefit, and in addition to just
What
traditional.
kind of medicine will you
So
be?
the other medicine that is also important in this space is a group of medicines called SGLT2 inhibitors.
Okay,
Right.
yeah.
So actually, when SGLT2 inhibitors came out, these were the first class of medicines that actually had this mortality benefit.
Okay.
Right, and it reduces risk of heart attack, heart failure, and all this kind of stuff.
In both men and women.
Men and women, yeah,
Okay.
that's right, yeah. And before Ozempic came out, actually, we were using SGLT2s a lot, and actually SGLT2s, because of the way it works and reducing inflammation and everything, people actually do lose weight with SGLT2s as well,
Right.
but probably not to the
Not to
degree,
the extent.
not to the degree as
Yeah.
with Ozempic.
I have heard of it being mentioned in some spheres as not in the diabetes treatment. They think that it can extend lifespan. But then, very funnily enough, it seems like it's only in men, not women.
Oh,
Yeah. But I think those are people with no diabetes. So I don't know. It's like metformin and people. Some believe that some people take for anti-aging and some they're the detractors. So I think it's that kind of space. Yeah. Okay. Yeah. So when you talk about this cardioprotective effect, it works even on people with no diabetes and say I'm taking it just for obesity, it will also be.
It does.
Then it sounds like a great medicine
for
for everyone.
Definitely. And that's also why there's been lots of interest and there's been a lot of hype about these medicines. But of course, we have to bear in mind, right, the not so nice things about semaglutide and stuff like that. So besides the common side effects, right, so it's relatively, it came out 2017. Right, Belsa's 2019, right? So it's relatively young drug.
So you don't know if there's any long-term problems.
Yeah, so so far in the years that it's been out on the market and everything, the drug companies do very strict post-marketing surveillance and all that kind of stuff, right? So there hasn't been any strong signal of anything very alarming. Right? But we do not know, right? 10 years from now, 20 years from now, 30 years from now, whether there will
as with all medicine, right?
Yeah, as with all medicine that is new. So the kind of things that sometimes pop up when you think about semaglutide is basically, one is this possible association with cancer.
Okay.
Right?
Okay.
And we are talking about a rather specific type of thyroid cancer called medullary thyroid cancer.
Okay.
So this in itself is a very rare form of thyroid cancer, but it's one of the more aggressive thyroid cancers.
Unfortunately.
So what happens, based on the trials and stuff like that, is that when they give this medicine to animals, so like rodent studies, correct, there seems to be an association with higher rates of this kind of cancer.
Okay.
Right. So far, it's not been translated to humans, right? So it's not being shown in the 8 years, that the drug has been used, that it seems to translate into increases of this kind of cancer in human beings. So sometimes patients will ask about this, right?
Yes.
So they read it on the internet or Google.
So that is still really a source of concern.
Correct. Yeah. So it's important also to elicit, the history from the family, from the patient. Like if they have a family history of thyroid cancer, particularly this type of thyroid cancer, or they have some risk factors. So there are certain endocrine conditions that are associated with a higher risk of getting this, right? So like multiple endocrine dysplasia.
Yeah.
If there's such a history in the family, then we would not prescribe this group of medicines to them, right? And probably have to explore other ways of helping them with the diabetes and weight loss.
Understand. Yeah. It sounds like, the diabetic landscape has changed so much.
Yes, it has.
How do you decide? In the old days, I remember it was always just a few drugs. Now you have a plethora of medicine to help with the management of diabetes. What would you say would determine what you're using? Is it, for Ozempic, do you only reserve it for people who also want to lose weight, or is cost a concern because it's really expensive? Yeah.
So I think you're right. So diabetes treatment landscape has really, really evolved. When I was like a house officer, we only had like those few options, right? So now we have like so much more, and the drugs do a lot more than just lowering sugars.
Yeah.
So how we decide like which treatment to use depends on a lot of factors actually, really. So how high the sugars are at the point of diagnosis, perhaps if, let's say, the sugar levels are very high, very uncontrolled, the patient is in a bad state, maybe they're in ketoacidosis, then we have to be a bit more aggressive therapy. Those usually will involve insulin. So if you're talking about like non-insulin kind of treatment, then you look at a few things. Also, weight is a consideration. If the patient needs help in losing weight, like BMI 30 or above, that kind of thing, then definitely Ozempic would be the first choice. If the patient has, maybe some strong cardiovascular risk, maybe they had came with a history of, heart attacks before,
then of course,
then we would be looking at probably a SGLT2 inhibitor or GLP-1s, right? Sometimes if they have like contraindications, maybe they can't take SGLT2s because they have recurrent infections, this kind of things, then, GLP-1 is an option, or other, the more traditional kind of diabetes medicines actually still do work well for sugar lowering lah.
Okay. So what's the contraindications to get something like Ozempic? Because you mentioned the thyroid. So all your patients with, say, thyroid issues, thyroid nodules, hyperthyroidism, hypothyroidism, are these not candidates?
So not really. So if it's hypothyroidism, these are not contraindications for Ozempic. If they have nodules, right, then I would probably work the nodule up first, make sure it's not make sure it's a benign nodule before I would prescribe them Ozempic lah. If risk is very high, right, like a family history, or they have a nodule looks highly suspicious, then I would be very, very cautious about giving them Ozempic. So patients with maybe autoimmune thyroid conditions and stuff like that, that in itself is not a contraindication lah. If you're talking about contraindications like type 1 diabetes, usually we don't give this type of usually type 1 diabetics will need insulin
they will
treatment
still need
more.
insulin,
Correct, so that I would say is some sort of like a contraindication.
Because that will mess with their appetite and then their insulin control.
And also the pathophysiology behind type 1 type 2 diabetes is a little bit different. So in type 1 patients, they usually will need insulin more than... Anyway, this group of medicines have not been that well studied in type 1 patients as well.
I see, So, this landscape seems to be changing all the time with new medicine coming out. I think I heard so many new medicine and I cannot remember the name, but I think Mounjaro was another one.
Yes.
Is that available in Singapore? Because that is like also a Hollywood... darling.
So Mounjaro came out after Ozempic. So Mounjaro maybe 2022, around those around that
period. So it's a new kid.
Yeah, it's a new kid on the block. But in terms of its efficacy for weight loss, right? It's said to be 20-25%. So it's much more efficacious than Ozempic, at least based on what we have seen. And it uses two mechanisms. Yes, that's right. So it's so while Ozempic acts on GLP, right? Mounjaro actually acts on more than one of we call it incretin hormones. So GIP and GLP. So it's like a dual agonist. So does that make it better for obesity and diabetic control? Potentially yes. So the efficacy is supposedly much higher, right? So we're talking about magnitude of like 20-25% with Mounjaro compared to Ozempic. So Mounjaro is not officially available in Singapore yet, but I've heard it's coming, right? And sometimes in patients who, let's say they have tried Ozempic for a while and, maybe they start off from a higher baseline, maybe the weight is really like BMI 40, that kind. They will need a more stronger agent to get really to improve the metabolic health. And there are ways that we can request for approval, bring the drug in. But yes, Mounjaro is do they have the same cardioprotective benefits of Ozempic? Same side effect profile? Side profile is probably similar because the medicine is probably is kind of like belong the same class, group, right? In terms of cardioprotective benefits, I believe there's a lot of trials and stuff like that going on, and it's probably on its way there. So again, they are also worried about the risk of cancer then, since it's the same class of drugs. So when somebody takes Ozempic, how do they actually feel? Do they feel like they eat and they can't eat so much, or because there's some delayed gastric emptying, or do they not hungry like my phentermines where they just don't have appetite? Some of my patients share with me is that they find it reduces the food noise lah. Right? So it's not that they don't feel hungry at all. Right? They still do feel hungry, but they find that they don't think about food all the time. They don't think about food all the time, and perhaps they can last a bit longer. Like patients tell me, oh, maybe today I have a meeting, late lunch. By the time it ends, I'm feeling like so hungry. I will go eat. But with the medicine, maybe they don't feel so much, so it really affects the brain, the signal, the hunger signal. And I also find that, if, even if they feel hungry and they need to eat, they don't really eat a lot to make them feel as full compared to before. So, maybe just half of what I usually eat compared to the past is enough to fill me up already. And if I go beyond that, let's say, I ignore my body signal and I eat beyond what some people do eat because they are stressed or sad or depressed. That's right. So some of my patients do share with me that maybe that day they have a party and then they want to eat a bit more. Sometimes they do feel a little bit sick after that because the medicine is working and it's telling you actually you don't need to eat so much. But if they still eat excessively, then sometimes it makes them feel a bit lousy lah after that.
Okay. So are there patients that don't respond to Ozempic in terms of diabetes and also in terms of obesity?
Yes, like I said, there's a spectrum of response. So there are patients who unfortunately don't see much weight loss, right?
Why do you think that's so?
Hard to predict actually at the outset.
Both men and women should respond equally?
They do respond equally. We don't see any difference in terms of response based on the gender. But some patients either don't respond or take much longer time to respond. I've had some cases like that as well.
So do you suddenly see a surge in patients coming to your clinic asking for Ozempic?
Yes, I do see these patients as well. I wouldn't say there's been a surge or huge demand. I think in Singapore we're still quite reasonable. Like in the sometimes in overseas, Ozempic went viral on TikTok, and then people are just getting it, and then one of the things that has resulted because of this huge demand for Ozempic is shortages.
Yes, isn't it crazy? A diabetic drug is now in shortage because people are using it for weight loss.
Yeah, I mean so because of the huge demand, huge interest, and there have been in the US like celebrity endorsements, like Elon Musk and Wegovy, etc. So that actually generated a huge boom, a huge interest, and that has resulted, unfortunately, in over demand, and the company cannot meet the supply. So even in Singapore, at one point, we also had kind of to deal with rationing of the stock, shortages, and things like that. And so these are kind of not so nice things that has resulted from this. So it becomes that the diabetic patients who really need it end up sometimes not being able to get their hands on medicine that they really need.
Yeah, because I think this is really best served for people with a bit of diabetes or some kind of obesity related medical conditions like obstructive sleep apnea or something. And so, if people are just using it for weight loss, it's taking it away from these people. So is there any last word that you can give us if there are patients interested in, say, losing weight and coming to you?
Weight loss is never so simple, right?
Yes.
Sometimes patients
one episode last few months we had an episode on sleep apnea, and one of the issues was obesity.
Yes.
So they are actually a candidate because most people don't think of going to see you for Ozempic if they have sleep apnea. They go and see an ENT who then tell them to lose weight.
And then they refer them to me.
Or they just go and exercise. If they knew that they were, because now people are thinking, if I don't have diabetes, I can't go and see you because but actually it is all related, I think.
It's all related. So, I mean, the official label for Ozempic is for diabetic patients. If you're non-diabetic, you're looking to lose weight, by right, it should be on Saxenda or Wegovy when it comes. But, because Saxenda is everyday injection,
that makes it a bit
something
difficult.
is a bit of a barrier for patients. So we use Ozempic sometimes in non-diabetic patients as well. If they have OSA, if they're obese, right? Of course, I wouldn't give them to patients who have normal BMI or who don't need to lose weight or just want to lose weight, maybe to look good and stuff like that. So that becomes a kind of like an ethical gray zone, gray area and stuff, right? I mean, as doctors, we have stewardship of these medicines. It's our responsibility to use it in the correct patients as well. So if let's say someone is overweight, maybe not diabetic yet, but if they don't do something about their weight or nobody helps them with their weight, it may be a matter of time before they
how would they define, how would they know they're pre-diabetic? So short of taking a blood test and finding their glucose being suboptimal.
So I mean, it has to be diagnosed on blood test, unfortunately. But if they have family history, right, or if they are a little bit overweight, or maybe they got high blood pressure, right, it's not.
So all these are already symptoms, like whole family history of people, of family members having diabetes, they're being overweight, high blood pressure. Then they should go for testing.
Definitely, they should, and that will increase the risk of getting diabetes or pre-diabetes.
And also one question I forgot to ask, for type 2 diabetes, when somebody loses weight, doesn't their type 2 diabetes improve by themselves? That's why some people believe, just by fasting. So if they can lose a lot of weight on Ozempic, then perhaps they can reduce their dose for glucose control.
Yes, so diabetes and weight is intimately related. So, with the weight comes insulin resistance, and then, you get the diabetes right? So
it's not a life sentence. You actually can do a lot of things.
So diabetes is a chronic condition, right? But with motivated patient, with regular follow-up medication, everything, the right medicines, having a right lifestyle, it can be controlled, right? And with good control, reduces risk of complications. So, coming back to what you mentioned about, like, if they take Ozempic, they lose a lot of weight, their diabetes improves. Yes. Yeah, that's what we hope to see and hope to achieve as well.
So do you have patients that were on medicine for type 2 and then went off medicine just by losing weight, lifestyle?
So I have
That's
patients
really encouraging.
who, started out, overweight, right? Borderline obese kind of thing. And then, sugar is not in a good place. I have to give them, start them with some medicines, metformin, not necessarily Ozempic, but, diabetic medicines, right? But if I had patients who are very motivated. Like one patient, she went to buy this, the Nintendo Switch game.
Oh yes,
I always share these stories. I always share the story of this patient and my other patients. So she went out to buy this Nintendo Switch and bought the dance game, the program. Right?
Yes.
And she actually played this game every day, 2 hours with her husband.
Really?
So both of them do dancing.
Oh my God.
And actually on her own, she managed to lose about 5 kilos.
How over a month?
Maybe 2 months.
That is very good.
Yeah. So, and what's more important beyond the losing weight part is that actually her diabetes improved. She also had fatty liver, hypertension, all these kind of things. And all her metabolic, parameters actually improved a lot just through that sheer weight loss alone. And eventually I took off medicine.
Yeah.
And I told her, continue what you're doing, it's also, endorphins. You're doing something you enjoy.
Yes.
It's not a chore.
Yeah.
It's something with your loved one, family members, and everyone can enjoy and take part in the activity together.
I think that's such an encouraging story to know that diabetes is not a life sentence. You can do something about it. And even somebody for obesity, they shouldn't think that they need Ozempic forever. You're not chained to it because there's so many other things you can do with your diet, your lifestyle, your Nintendo Switch. But maybe these things can help kickstart you in the right direction. I think that should be the correct way to use medicine.
Yeah. Not forgetting nowadays we talk a lot about mental health, stress management. Sometimes I find that is a neglected part of, overall, when it comes to managing obesity. And I think as doctors, sometimes you find it tricky or difficult, or maybe not comfortable to talk about these sort of things with your patient. And, maybe my own personal experience is that, I don't have a medicine to help you with your stress management, right? It's I feel like I can't really help. But it's actually important to talk these things out with your patient as well. Because, weight is not just a behavioral thing, right? A lot of times, that behavior is also being driven by other factors, right? And patient may be struggling with mental health issues or, body image issues and things like that. So, it may not be something that you can, it takes you need to build a bit of rapport before patient is comfortable sharing these kind of things with you. And it may take a bit of time before these things surface. So, it's a journey lah. Right? It's not like I just give Ozempic, you lose 10 kg and end story kind of thing.
So that may just be the band-aid. You're right.
Correct. So, sometimes some patients,
women always eat when they're stressed. Then even with Ozempic, you will still eat if you're stressed.
So sometimes it boils down also to, maybe helping them talk through stress management strategies and things like that. And sometimes if really need be, we refer them to mental health professionals.
I think one of the problems I see with Ozempic is that because a lot of girls go on social media and they want to be very skinny and they think that if they have this quick fix and they don't have to do anything, they will solve their problems. But because they don't address other issues like mental health, the stress, why do they think they're fat when they're not fat? And exercise and diet, then how can it be sustainable? Because this medicine is not a one shot and it'll last forever. When you stop and you have nothing to fall back on, then
you're totally right. You're totally right. So we are fortunate in a way that we are living in a time where there are good treatments for obesity where we previously never had. Right? And patients now have a fighting chance of actually really getting better and really improving their health. So, I try to emphasize to them, taking all these medicines is health over appearance. Right? Right. Ultimately, it's actually is for the good of your health in the long run and everything.
But so open for abuse.
yes, exactly.
So we have to police that.
So we have to be careful about how we select patients and because these drugs are not without side effects and they are not cheap by any means. Right? So we have I always make sure that I have a very open discussion, very frank discussion with my patients regarding the cost, how long they need to be on, what the side effects they're going to expect, what happens if you stop medicine, are there any other options, right? So it takes time, but I think it's worthwhile to do this lah.
Okay. So I think the take-home message is if I have $500, I'll go and buy the Nintendo Switch and not 1 month's supply of Ozempic, because I think that will last me longer. Okay. Thank you so much, Daphne. Thank you, Dr. Lee, for sharing your insights and helping demystify the use of Ozempic for weight loss. And thank you, our listeners, for tuning in. It's discussions like these that empower us with knowledge to make informed decisions about our health. If you enjoyed our deep dive into Ozempic and want to stay updated on the latest in health and wellness, don't forget to subscribe to our podcast and share it with friends and family. Join us next time as we continue to explore fascinating medical topics and trends that affect us all. Until then, stay healthy and stay informed.